Thanks for joining. I wanted to talk a bit today about the concept of memory reconsolidation and how kind of understanding it and using it in psychotherapy can improve your clinical outcomes. A little bit about myself. I currently am a medical director at TriWest Healthcare Alliance, getting credentialed to provide some clinical services on Lanai, hopefully fairly soon. And previously had been in the Army. I had a career in the Army and was stationed at Tripler and Schofield Barracks, as well as in the Washington, D.C. area. I heard that someone was there. I spent probably half my career in DC and half my career here in Hawaii. Then worked for an adolescent partial hospitalization program for a little bit, then a telehealth outpatient type of company before joining TriWest about a year and a half ago. I live on Oahu in Kailua, and I know at least one person on this talk was one of my trainees for accelerated resolution therapy, which is something that I have as kind of a side gig. I do some trainings in that, which I have found to be personally the most effective treatment that I've stumbled across for trauma, anxiety, grief, and a lot of other things. Oops, sorry, I'm trying to go down. Let's see. Okay. So, just a couple disclaimers to start out with. One, these are my views alone. They don't reflect the position of my employer, TriWest. And as I mentioned, I am a certified trainer of ART, and I'm paid by the founder's company, which is Rosa Center for Rapid Recovery, for my training engagements. I've tried to be fairly non-biased when it comes to presenting memory reconsolidation, but ART is a type of therapy that uses that. So, just wanted to mention that up front. The learning objectives for today are to explain the memory reconsolidation process, talk about how the psychotherapies that leverage memory reconsolidation are different than the traditional psychotherapies you might think about or have learned, and then describe the importance of identifying the patient's underlying cognitive schemas when using these types of therapy techniques. I was going to talk about how I became interested in this topic before I get into what memory reconsolidation actually is and why it's important in psychotherapy. Again, trying to differentiate those therapies that explicitly use memory reconsolidation from those that are more traditional and may kind of just stumble upon it every now and then. And then try and help you understand some of the principles that can help you optimize your outcomes in therapy by understanding memory reconsolidation and definitely touch on the importance of cognitive schemas and then have some time available for Q&A, which reminds me I want to get my watch in front of me here so I can understand where we are with time. So just to start out, I pulled this from ChatGPT as kind of a schematic to kind of help everyone understand my path to where I got to this point. And I decided it really kind of started in medical school when I was deciding between psychiatry and surgery. They were the specialties that intrigued me the most. And actually, I found out later that at least one of the surgical attendings said that, there's actually a lot of overlap in the sense that both are fields of medicine that don't have an algorithmic cookie cutter approach. There are some best practices, but once you kind of open someone up, so to speak, you're on your own and have to rely on your own skills and expertise to figure out the best way to tackle the problem that you're trying to help with. So you can see on the right, I was really intrigued by the connection between people. I loved hearing about the different histories, and I loved psychotic individuals and trying to figure out how the brain could present in such an unusual way. Things like dissociation and hallucinations. I thought those were so fascinating. And I really liked getting to know the patients and hear their stories. On the other hand, I tend to be kind of impatient. The surgical things that interested me were the fact that, you take care of things very quickly. Once you're done, you're usually done unless there's a complication. The results are very tangible. For someone who's fairly impatient, it's a very compatible specialty. So obviously I chose psychiatry for a number of reasons, but I still in the back of my mind kind of like this idea of trying to figure out a rapid way to treat pathology. So in 2013, I had been in Hawaii for about 10 years during kind of the height of the engagements in Iraq and Afghanistan. I had deployed myself. I had treated soldiers up at Schofield and Tripler, and had really been frustrated trying to address their trauma because I felt like medications really weren't that effective, and the treatments I was using either made them worse and kind of destabilized them, or in the case of prolonged exposure, they just literally would like begging me to stop putting them through the same trauma, talking about it over and over and over, which I didn't really like either. And so I had just moved back to another assignment in the Washington, D.C. area at Fort Belvoir, and this article had been published. And the thing that had kind of intrigued me about this article was this kind of bottom line about ART, and it had been delivered in an average of 3.7 sessions, 94% completion, which already was amazing because most of the patients I was trying to treat with trauma therapies were kind of running out of my office. And then they saw really significant improvement, specifically 65% response rate that had persisted at 3 months. And I said, man, I really want to get to know these researchers and try to figure out what this is, maybe get trained in it. And uniquely enough, a colleague of mine at Walter Reed, which was up the street, had called me around that time and said, hey, this group came and talked to us, and they kind of got laughed out of the room, but I think there's something there. I think they have a technique that might be helpful. Would you be willing to host a training there at Fort Belvoir? And so I made it happen, and we hosted a training of just 6 people initially. This was back in 2014. And I found the results of ART to be so immediately successful and dramatic that I arranged funding, and ultimately we got over 100 people in the DC area trained. One of those individuals, Mill Brown, whom some of you may know, was transferred to Tripler, and he got a bunch of people on Oahu trained right before COVID. And then there was a bit of a break until I started training people a couple years ago here. So just kind of based on the currently published literature, this is how ART, which is one therapy that uses memory reconsolidation, stacks up against those that we commonly use for trauma. These are kind of considered the gold standards, and you can see that the response rates are pretty good in most cases, but the dropout rates tend to be high. And the dropout rate for ART is typically about half that of these other therapies, although there was one study that followed an arm of homeless individuals or unhoused individuals and found that their dropout rate was, probably not surprisingly pretty high at 48%. But the number of sessions you can see is significantly lower than these other therapies. And this is again in the published literature. So there have been a few studies. It's kind of outside the scope of this talk, but I'm happy to share them with this community if there's interest. So what is memory reconsolidation? Well, I went to Copilot just because I thought, it might be the best way to kind of summarize what's known. And I agree with this definition based on my reading. So memory reconsolidation is the brain's process of updating existing memory after it's been recalled. It's one of the most important discoveries in modern neuroscience because it shows that memories are not fixed, they can be changed. So anytime we think about something that happened in the past, we're activating that memory, kind of opening up that window of memory reconsolidation. And what scientists have found is that those memories are kind of modifiable. So one way to think about it, an analogy that's often used is if you think of the memories as being kind of like computer files. So they are changeable. You can open up a Word document and make some edits to it and save it again, but it's not accessible until you actually open the file. So just like a computer file, these memories are kind of locked away until we activate them, meaning kind of direct attention toward them. And then once they're activated, they are modifiable before we kind of put them back away and save them again, if you will. So why is memory reconsolidation important in therapy? I'm going to give you kind of a little example that might be helpful to elucidate this better. So, oh, actually, sorry, that's in a couple slides, but to kind of highlight the important point. So negative emotional states often involve mental reactions to earlier memories. I think most of you understand that. If you have something bad that happened in the past and you think about it, you might feel bad again today. The more distressing the memory, usually the easier it is to retrieve. Those things that were difficult are kind of at the forefront of our mind, except for in the case of, dissociation, where we've where we have a coping skill or a defense mechanism that literally blocks it off from our conscious awareness. But also, unconscious emotional reactions to past memories can manifest during therapy sessions. So I'm sure many of you have been in a session where there's some sort of reaction the client or patient is having, and you're like, you know what, this is bigger than this room. This is based on something that happened in the past. Either the patient's aware of that or they're just unconsciously kind of playing it out again, that dynamic. And finally, physical disease can also be rooted in past events. So things like headaches, chronic pain, functional conditions can represent problems from the past that are kind of still stuck. Many of you are familiar with the little phrase, the issues in the tissue, or Van der Kolk's book, The Body Keeps the Score. That's kind of what this is alluding to. That memory reconsolidation window after you open up or activate the memory is thought to be about 5 hours long, and this is based on scientific studies. So we have about 5 hours, but this is, this picture of the hourglass is one way to think about it. I also like to think of a snow globe. When you activate the memory, you shake it up, and in the beginning, there's the most activity. So that's kind of your window of change is really in the beginning. As that window slowly closes, the memory becomes more and more resistant to change. So it's not like you have 5 hours, like the equal ability to modify those memories within the 5 hours. It's biggest in the beginning, and then it kind of those memories become less and less resistant to change the longer it goes on. Okay, so here's the graphic I was going to try and show you. So let's say someone has been bitten by a dog somewhere in the past. So they had a really terrible accident with a dog. They were bitten and they've been very scared of dogs. Well, after the initial bite, that memory of being bitten by the dog will eventually consolidate. It may take some time, but ultimately it'll usually go into long-term storage. And unless the individual is re-triggered, they're not going to be thinking about their dog bite on a regular basis. But let's say they're walking along the street and they encounter a regular dog, not a scary dog, maybe even a cute little dog. But because of their past experience, that regular dog may activate that memory of being bitten by the dog. And so they may perceive that regular dog as being very scary and experience some of the same sensations and emotions that they had when they were initially bitten by the dog. If you just kind of let it go, if they, move along the sidewalk and they just go back to their day, ultimately that within the 5 hours, like I mentioned, that memory will reconsolidate and the memory of the dog will be there probably about the same because nothing really big has happened during that time. So it'll be tucked back away, the file will be stored again, but there's not going to be a lot of change. With traditional psychotherapy such as CBT or mindfulness-based stress reduction or something like that, you may get some decrease in the kind of tenacity of that dog. So instead of those big, scary, sharp teeth, maybe you get a little like ankle biter. The person is perceiving dogs as kind of something that makes them feel uncomfortable, but they're no longer having that severe fight or flight reaction, but they're still not fully recovered. But if you were to utilize a memory reconsolidation approach, you can actually turn that kind of consolidated memory or reconsolidated memory into something more positive, something that may actually help them not have any negative sensations or emotions at all, where they think about it, maybe they feel calm, or maybe they even feel happy, and laugh. That would be the ultimate kind of outcome, the best outcome, right? So, how are memory reconsolidation therapies different from traditional? Well, one way to think about them is they're just faster. You look at the time course of improvement for traditional psychotherapies, it tends to take some time, 10 to 12 sessions on average for CBT. They're doing their homework, they're doing their graded exposure, they're practicing. It really can take some time. Whereas memory reconsolidation based therapies tend to work very quickly. So each session tends to have pretty big improvements once you're actually doing the psychotherapy. Now, there may be some prep sessions before that, and that would be indicated on this slide by that, really short little dark red line where you're just kind of taking the history, getting to know them better. But then as you start to implement the therapy, their symptoms typically reduce very dramatically. So some of you may be wondering, well, what are some memory-based therapies and what are some regular therapies or traditional therapies? So I've just kind of listed some here. The ones on the left you're probably much more familiar with because they've been around a lot longer and they've been studied much more robustly. Um, Hopefully you're familiar with a lot of those acronyms. On the right, the kind of leading memory reconsolidation-based psychotherapy is called coherence therapy, and that was developed by a guy named Bruce Ecker out of not Beverly Hills, Berkeley, sorry, California. And he's done some writing, and I actually forwarded an article by Dr. Ecker. I think he's a doctor, but I know he's a social worker. Forwarded an article to the staff that might be able to attach this to the Echo platform so that you can see that article. That article very nicely kind of talks about the difference between traditional therapies and memory reconsolidation based therapies. My favorite, as I mentioned, is ART, which is next on the list. There's another one that recently was published in a head-to-head trial against, I think it was CPT, and that's Reconsolidation of Traumatic Memories, which is based on neurolinguistics. Then there's something called nightmare reconstruction therapy, which is being looked at. And then critical memory integration. I have been trained in that one is a little more passive, but equally effective for those providers that are good at it. And then emotion focused therapy, I'm not as familiar with, but I do know it's often cited as having some relevance to memory reconsolidation. So this is another graphic to just think about like traditional psychotherapies, you have an appointment, you kind of may do, if you think of a dental analogy, you may take some films, you may clean the teeth, you may put a little numbing, medicine on the gums, or you may prescribe some pills. It's always a little bit different. And the gains, overall the tooth improves, but there's not like a really dramatic change. Whereas with memory reconsolidation based psychotherapies, you want to think more like a root canal. You're taking that disease or that terrible memory out, you're just plucking it out, cleaning the area and putting a brand new, reconstructed tooth back in there. So it's much faster and kind of impervious to change or resistant to change.
There is a question. Amber asks, where does EMDR go? Is it
That's
MR?
a sorry, that's a great question. So I think many EMDR, now I was trained in EMDR many years ago and honestly didn't have a great response with it. So I kind of put it aside and wasn't one of those individuals that really got to know it and, got further training. I think EMDR as a kind of foundational, if you're just trained very basically in it is not necessarily based in memory reconsolidation, but there are certainly sessions of EMDR that can utilize memory reconsolidation. And I guess as I go through this, I'd love to hear during the Q&A how some of the EMDR trained therapists feel that it fits into this, because I do think it's there. It might be kind of in the middle, maybe toward the right a little bit, but it's a unique one. That's a great question.
And just by the way, Miley says hi, and Michelle Rocket says she's in your distro for art, was trained
Okay.
at Schofield. So
Great. Good to hear from them. Awesome. Okay. So again, with ART, or sorry, not so ART, with any of these therapies, the goal is really to achieve transformational change, which is radical, dramatic, large in scale. So some of the things we know is that I've talked about a lot of this already. Memories can be modified more dramatically than usual when the reconsolidation process is disrupted. Things that can disrupt that process are medications. So propranolol is one that's been studied a lot in changing the mind's ability to, or the brain's ability to consolidate those memories. Now, the medication doesn't in and of itself change the memories or modify them. It just kind of prevents reconsolidation in the usual way. For psychodynamic fans, an appropriately timed intervention can have the same response. So that's why sometimes, Freud encountered wonderful sessions where he would have dramatic responses. And I think a lot of times it was because he had actually helped the client change their view of the world, change their schema during this memory reconsolidation window. And then introducing a prediction error, which is a mismatch between what the patient expects and what they experience during a session, can create lasting changes. And we're going to talk a little bit more about that. So, what I kind of say is a winning therapy ticket, and this is based on the literature that I've read pretty extensively on memory reconsolidation, is that, and then certainly what I've seen in practice with ART is that if you activate the distressing memory, meaning like you kind of bring it up, the patient thinks about it, you start to witness some either emotional or even physical response to that memory. And then you find a way to introduce a prediction error, meaning that they're expecting to feel the way they've always felt with this memory, and now they feel a different way. And then you make the modifications, or in the case of many of these therapies, you help the client make their own modifications and then reinforce that modification to kind of help their brain look preferentially at the new version or the more relaxing version or the happier memory as opposed to the really bad one. So that formula, if you kind of can incorporate that into whatever therapy technique you're using, is likely to have a very positive response. So, what is a prediction error? So, I kind of explained this or just defined it a second ago, but it's basically when you think or the client thinks that they're going to feel a certain way because they've always felt that certain way when this thing happens, and then something happens to change the way they feel. So, I like to use these analogies. When you think you've lost your wallet and you're certain that it's gone, or your purse and you can't find it, that panic that sets in, that the kind of list that starts up in your mind about all the different things that could go wrong, the different charges that could be filed, the people you have to call to cancel it, all that panic. And then, you pick up a garment and there it is under the garment. And then all of a sudden that panic kind of melts away, right? You don't continue to fret about it because you found it. And now you may check it and make sure everything's there. But in general, the anxiety is gone. Same thing with when you think you failed an exam and you're certain that it's gone south, and you start to think about that you're not going to have the career you wanted, or the future that you had hoped for yourself. And then you find out that you passed. I mean, usually you don't continue to fret about that. You feel actually a lot more confident, right? You often feel like, oh, maybe I'm pretty good at this. And then similarly, if you're sure you're seriously injured or ill, and then you get the lab results back and things are fine, usually you're going to not worry about it anymore. So the key during this reconsolidation window is to modify the memory. So if you don't do anything like we talked about with the dog example, the person just keeps walking along the sidewalk, you're not likely to get that prediction error. So if the client in your office brings up a distressing memory and you kind of move past it without doing much, nothing is likely to change. If you provide a calming intervention or medication like propranolol, if your office is, warm, inviting, your manner of interacting with the individual is calming and reassuring, then there may be a chance that a prediction error could occur because they may actually feel more calm or more reassured than they normally would. It's less likely than if you do something definitive, but it certainly doesn't hurt. If you kind of help the client imagine, for example, that it didn't happen, maybe they can do that on their own, or maybe you can, um, introduce some ideas like, hey, pretend on this other screen in your mind that the thing didn't happen. You were just driving and there was no car accident, you just kept on driving. Then that makes things a little more likely, especially if they can visualize that really clearly and even think about what it might feel like to have not had the accident, and maybe think about a time when they drove and there was no accident and they actually felt pretty confident about their driving. That increases the likelihood of that prediction error. But if you actually can figure out a way to address their underlying schema, such as, I'm a terrible driver, I'm always going to get into accidents. If they have that kind of schema, and especially if you figure out where it came from, like because their mother always told them they're never going to be a good driver or whatever, if you can somehow find a way to change the way they feel and challenge that belief system, and with ART, we do that kind of with the mental imagery, then you'll be more likely to induce that prediction error. So as an example, we talked about with the dog, if a dog bite victim imagines dogs before any kind of trauma-focused therapy, they're going to continue to, yeah, they're going to continue to imagine them very frighteningly. If they do have some, traditional trauma-focused therapy that doesn't really work on memory reconsolidation, they'll probably get to the point where they can think of dogs as fairly benign and not really be bothered by them most of the time. But if you have a patient who you've been able to challenge that underlying schema and maybe even have them think about dogs in a fun way, that dogs can be a joy-producing part of their life, um, then they might have that kind of as their mental schema, and that will introduce that prediction error and help them feel better. An example in the military, if you don't do anything, they're going to picture things just the way they happened. If you do most trauma-focused therapies, they might get to the point where they have a fairly benign image that comes to mind of their lost buddy. But if you use memory reconsolidation, you have the opportunity to change that mental image to something really fun and memorable and a way that that person would really love to be remembered. And even if you have someone in your life that's still there and you're facing every day, like a boss who's toxic or a spouse or someone that just annoys the heck out of you, if you can kind of change the image or the way that they think about that individual during this memory reconsolidation window, especially if they can change it into something kind of not intimidating or even hilarious, then that person will typically become much less um, activating for the client. So some may wonder, is it okay to change memories? There's an ethical question here, and I think it's good to have that question. But if you think about it almost from like a journalistic perspective, right? If I'm a journalist and I'm writing a story about a fire, I could choose to include this picture, which I would personally not choose to include because I think it's very scary. It's very graphic. It brings up a lot of negative feelings, perhaps even for some of you on the call. Or I could choose this picture to show my news story, which kind of highlights the professionalism of the first responders, the work of the firefighters. You're still telling the same story, but the images or the kind of emotion that's being generated from that story is quite different. And this gets to the difference between explicit memory and implicit or semantic memory. With these therapies, you do not change the explicit memory. The facts always remain. It's the feelings and sensations, the implicit memory that we want to change. So some pro tips for those of you that are, either already using some of these therapies or are thinking about trying to do this in your normal therapy techniques or protocols. You want to try and apply those interventions as soon as the memory is activated. Because as I mentioned, the longer that window goes on of the 5 hours, the more impervious to change that memory is going to be. So it doesn't mean you have to jump in there immediately, but within the hour of your session or so, you want to try and address it. Um, you don't want to really dig into the details of the memory, and if you don't need to, first of all, because all you need to do is activate it, which just requires the individual to think about it. And then getting into the details can actually create some exposure and desensitization leading to extinction, which actually can be counter-therapeutic because we want that prediction error to come about based on the significance of the sensations or emotions. And then extinction, which is the basis of traditional exposure-based therapies, where you have your kind of hierarchy of fears and you walk them through kind of challenging themselves to face their fears. That actually is known to create a new memory trace that competes with the original, but it doesn't replace it. And that's why those are felt to be kind of less effective in the long run, those types of therapies. And the article that I'm hoping is going to be able to be attached gets into that a little more. So I thought it might be helpful to talk through a case, and this will really get at the schemas and the importance of schemas or perspectives as we do this type of work. So imagine a 44-year-old war veteran with PTSD from combat exposure, and he comes in and he says, this is what I want to work on. I was in a convoy in Iraq, and the vehicle ahead of me hit this huge IED, which stands for intermittent explosive device, and it's big bomb, and there were body parts everywhere, right? That sounds like a really scary event and probably something good to try and work on in trauma therapy. And you ask more about the case or the story, and he says, well, I was a squad leader and I ordered my medic to help with the casualties. And then there was a secondary IED, like a second bomb that went off, and she was seriously injured. And then 2 weeks after that, he was playing basketball kind of on a down day and ended up breaking his ankle and spent the final 3 months of his deployment at home. So this is a pretty typical case that we see in the military, and I'm sure those of you that work with first responders might see something similar to this. And hopefully you're kind of thinking about these types of questions. So obviously you want to know how is he feeling about this event, and he may be telling you right up front because that's the whole reason he's seeking treatment. But you would also probably want to know how was he feeling about the deployment in general. I think those of us that aren't necessarily on the front lines that are involved in this type of work might not realize that there's a sense of reward and pride that comes from being able to do your job under austere conditions, even if your life is in danger. So wanting to clarify if that was the case for him or not. But looking back, like when he was a young boy, what was his role in the family? Because he's kind of the family leader of this squad, right? So we want to know what were the expectations he brought in. Also, how does he tend to manage adversities? He's someone who charges uh, toward the fight, or does out when people are, under high stress and exhibiting a lot of emotion. What is his worldview? What were his thoughts about why his unit was there? What the Army's position was, and did it make any sense? Um, his military position, being that squad leader, was that significant at all? And are there other things that you would want to know? So hopefully you're kind of thinking about those types of things. Um, he also mentions, he stopped going to the VA years ago because he felt like no one cared. He's tried every med under the sun. All the therapists he's seen either did nothing or made his PTSD worse. And the only reason he's seeing you is because he promised his wife he would try one more time. So, you're getting a sense he's kind of at the end of his rope. He's really stressed out. He's disillusioned with the healthcare system. On the other hand, he's kind of putting you on the spot, right? He's putting a lot of expectation in your ability to treat him, which can be indicative of his underlying schemas, but also can create a lot of stress for the therapist, right? So he brought in this memory that he wants to work on to this event. You should be thinking about how do you know if it's a good one to target? In a sense, you don't want to be the one driving the train, but on the other hand, your clinical experience will hopefully help the client decide where to start, right? And that's on the more conventional side, that's why you make that hierarchy of fears and you don't start at the very top. You start kind of somewhere toward the bottom, right, to give people a sense of confidence as they work their way through that. Well, when you're trying to use memory reconsolidation, first of all, you want to work on a memory that evokes emotion. If it doesn't evoke a lot of emotion, if you're not seeing any kind of distress in the patient as they're telling you about it, if you're not seeing them choke up or their skin turn a little red or their eyes get a little teary, if they look perfectly calm, then it may not be the best memory to work on. Um, you also want to ideally work on something that really highlights that patient's schemas or the way that they see the world. So in this case, maybe you found out that this patient had a role in the family where he was kind of seen as the protector or the provider. He also seems to believe that he should have anticipated the second IED and not sent his medic to help people. Perhaps he told you that he was the one that should have died instead of other people, and that he doesn't deserve to live. All those are very important schemas that you want to kind of keep in mind because if you can change those schemas, you've really changed the power of that memory and hopefully dissipated the power of it. And then finally, even though he might have a lot of hesitation and reservations, ultimately you want to make sure that the patient's motivated to address the problem. If you think it's a good memory, but they don't or they're not willing to go there, then it's probably not yet a good memory. Some other things you might want to be thinking about in this particular case, we talked about worldview, the schemas that might be fueling his distress. When you think about what alternative or new version might be the most helpful for him, you should be kind of thinking about, he was in a very vulnerable position. Even though he was the leader, he experienced these two bombs that went off that he had no control over. So did he need to kind of be better protected or helped or even rescued? Um, were there things that he might have wanted to say to the people that he lost that he was never able to say? Were there experiences with them that he would have wanted to have, or even without them? I think I mentioned in this case, he broke his ankle and had to leave before the end of the deployment, so he may feel like he missed out or somehow left the team, up in the air. In this case, let's say we explored it and these were some of the schemas that came out. The world is unsafe, can't control it. I failed to protect people that were in my charge. And then drawing from that, I'm incompetent and I'm worthless. Um, you as a therapist hopefully can kind of at least speculate about these things, but if you can help the client put them into words or even write them down, it's super, super helpful, regardless of what therapy you're doing. Just being able to understand the why behind their symptoms is very, very important. And this is hard. I don't want to imply that this is an easy task. I struggle with it, every day I see patients. I think a lot of times they'll bring up a story and I'll make a presumption in my mind about why that memory or why that event was significant to them. And if I fail to explore it or get to know them um, thoroughly enough, then I often kind of miss the mark. So I'm really trying to get better myself at making sure that I fully explore and specify the underlying cognitive schemas so that I can address them. If you make suggestions as part of your therapy, those suggestions are critically important because sometimes that can be really helpful to plant the seed with the patient that, for example, it's okay to say goodbye to those that you've left behind. It's okay to move on with your life, or it's okay to be vulnerable. That perhaps, you're going to be helping someone else out if you can imagine them being able to teach you a skill or protect you in a way that you weren't protected. So, being able to provide those suggestions during your therapy sessions is very, very helpful. So for this particular case, what suggestions came to mind just for me as I was thinking about it? And again, this is a made up case, but let's say you could say to him, well, let's say, on the other screen in your mind, instead of looking at the event that actually happened in the other screen, you're seeing a sci-fi movie, instead of Iraq. It's all Hollywood, it's not even real. Or maybe you were in an environment where you were highly trained, you had more support, you weren't as susceptible. You had a special device that could detect these IEDs and you didn't have to just wait for them to blow up out of the blue. You can see some other, I won't read through all these, but these are other suggestions that you could have had or that the service member, the patient might have came up with in this case that would ideally address some of those difficult cognitive schemas that were making him feel so bad. Now, you're not changing the thing that actually happened. You're just kind of providing some suggestions for ways that he could, like almost an alternate universe or an alternate way of playing this out in his mind, different movie to watch, if you will. So let's say, with this case, he was able to come up with this new version, right? So he got permission to reward his squad with a trip to the beach for some R&R, right? So he was able to take care of that need to be a protector and instead of, dressed in their combat fatigues with all their gear, they were able to just wear board shorts and t-shirts. For some reason, they were allowed to drive their military vehicles along the sand, and so they didn't have to, worry about roadside bombs. There were some booms, but maybe they came from fireworks instead of an actual, device. And the squad told him he had to go home early to spend time with his family instead of him breaking his ankle, and having to go home um, based on that. And then the medic, told him not to worry. She kind of gave him permission to let her take care of the squad. That it was her duty to go check on people, make sure they were partying safely. So how do you make it stick? So you remember that we talked about kind of the four-step process. So the first step is activating the memory. The second step is introducing a prediction error. The third step is creating some sort of kind of different way of thinking about things, a challenge to the cognitive schemas. And then the fourth step is kind of repeating it, over and over to, or at least somehow figuring out a way for the brain to look preferentially at this different way of thinking about things and also allow the body to feel differently. So a lot of different things have been used or explored. I don't think there's necessarily any one right way to do this. EMDR and ART use bilateral stimulation, usually eye movements. Some people use tapping devices or body taps with hands and whatnot. There are also therapies or therapists that have people visualize, a different reality or a different way of thinking about this, talking about it, writing it out, drawing it out, playing it out with clay or sand tables, dolls in the case of children, perhaps. And then those of you that are prescribers, maybe even using propranolol to figure out a way to help this new version or this new way of this new prediction error, if you will, stick. If anyone wants to read more about or learn more about memory reconsolidation, I would recommend these tools. The middle one is a YouTube video. I don't know if anyone watches the videos by Dr. Tori Olds, but she's a psychologist and she has a lot of reviews on different types of therapy, kind of big, big picture reviews so that you can kind of figure out what it's about before you invest money in getting trained in it. But she has one on memory reconsolidation. It's something like version 4 or, number 4 or something, but it's, I think, very good. And I like to watch that one. It's a nice overview. The book on the left is kind of a summary of a lot of papers written by people in this field, both in the basic science side and the clinical side. It's pretty dense, but it's kind of like a wonderful compilation of the current status of research. And then the book on the right, I just started reading. It was released, I think, earlier this year, if not about schema therapy and how to identify schemas if you're going to be working with memory reconsolidation, since that's such a critical part of the process. Okay, these are my references, and I figured I would stop there for questions.
How fascinating. Um, there aren't any questions in the chat, so let me simplify this down and you can tell me that I've Oh, there is a question. Okay, James asks, so the key intervention is to prepare the patient with an alternative memory to bring up when the trauma is activated by recall or an event. Um, does that sound right?
I would say not exactly to that. Not that it's a possible way of addressing this, but I wouldn't say it's a key intervention. The key intervention really is to introduce that prediction error. So to try and think of a way to help the client feel differently than they normally feel when they're thinking about that memory or that trauma. Like I said, it could be as simple as just having a welcoming, office and a pleasant way of interacting with them that might start to help them feel differently. But a lot of times, it could be imagining an alternate reality, or the paper that I had attached uses, or that hopefully has been made available,
I have.
talks about an example where in coherence therapy, they have the client kind of visualize two screens in their mind. And on the second screen, it's a memory or some sort of situation that makes them feel much differently. So it may not even be directly related. And I think just based on my experience with ART, it's ideal if the client can come up with this alternate memory on their own. You can plant some suggestions, but if you try and tell them that they should think about this a certain way, that may not land as well as if they're able to come up with it on their own. So by using Socratic questioning, saying, well, you know, how might you approach this differently? Or if you could do this over again, what would an ideal, solution be? Perhaps you could do such and such and such. That might be a nice way of introducing that prediction error.
So Randy asks, are outright untruths suggested as potential interventions? Sounds like no.
Well, with ART, we actually talk about using dream language, and that people can, incorporate all kinds of fantastical things that wouldn't really happen in real life. Neurolinguistic programming also talks about, maybe turning it into a cartoon or blurring it out or playing it backwards or, turning it from black and white into color or color to black and white. So, I think with little kids, ART, I've given them, allowed them to give themselves special powers. You can have patients imagine that folks are growing, shrinking, developing warts, becoming squishable, or whatever kind of helps that individual feel more comfortable with that memory, more confident. I don't know if that helps, if that answers the question.
Kind of. Mary asked, does ART and memory reconsolidation have long-lasting effects, like years? When is it contraindicated and does it work for CPTSD? So three questions, and they're in the
Yeah.
chat. You can probably see them.
Yeah, yeah. So the research on ART goes out to 3 months, I believe, is the longest observation in a published clinical trial. There's an unpublished clinical trial that looked up to a year out, I believe, but it's not been published yet, so I can't comment on that. Overall, the results sounded pretty promising, but again, things could change once it undergoes peer review. As far as some of the other therapies, the general gist, the anecdotal response at least, is that it is very persistent. And my personal experience, with it, and a lot of the experience of the ART providers I've trained is that these changes tend to last. Now, if someone, has a wonderful response, but let's say they're working on a car accident and they get into another car accident, well, that could, re-trigger some of this. So they may need occasional booster sessions, but that, 3 to 4 sessions seems to hold true for ART, RTM, which stands for Reconsolidation of Traumatic Memories, and maybe a slightly lesser extent for cognitive, I mean, not cognitive, coherence therapy. They were more, let's see, when is it contraindicated? Well, in complex PTSD, that's kind of, I'm going to combine those two because the real issue there, I think, tends to be about dissociation. And, if someone's going to dissociate into a state where they're no longer able to engage in the therapy, and I think it's really important with whatever therapy you're doing to make sure they have appropriate coping skills and resourcing before you tackle that. That question comes up a lot when I'm working with ART. And I personally don't use it for those populations, but I do know a lot of therapists who have used it successfully. And I think it has to do a lot with, making sure that when you activate that memory, you don't dig too deep. Just hitting the wave tops. We've started to talk in the field a lot more about kind of seeing a movie trailer, or a reel in your mind where you're just seeing flashes of little video snippets, instead of like an entire scene in great detail, because that's all that's really needed to activate it. But I would definitely, not engage with this type of approach with a complex patient or dissociating patient unless you've really done your homework and maybe gotten trained in one of these therapies. ART, do you want me to just read through the questions there, Morgan?
Go ahead.
Is
I
that
was going to ask you, but no point. You can see them now.
Yeah.
Yeah, yeah. Good.
Allison, hi, Allison. She wanted to know, can you use ART in patients with brain injuries or difficulty with eye movements? So it certainly has been used in patients with brain injuries. A lot of patients that report difficulty with eye movements when you first start out using eye movements will end up kind of improving over a pretty short period of time. So when I'm training ART providers, I usually just encourage them to start really slow, and as the individual tolerates, just increase the speed of those eye movements. If even doing that, they're really not able to tolerate it, then you might need to take a different approach. But I think it's certainly worth a shot, both with brain injury patients and people who report difficulty with eye movements. The only exception might be if someone has a uncontrolled seizure disorder, because kind of rapid back and forth eye movements can trigger a seizure. So if they are having recent seizures or their medications are not fully controlled, or even if they're on pretty decent medications for their seizures, it's good to check with their neurologist or primary care doc before you engage in that. How does the rapport with the therapist impact treatment outcomes? I'm not sure that's been fully explored in the literature, but I mean, I think there's good evidence in the historic literature to support this, that in general, treatment response improves with the therapeutic alliance. I think, with ART, for example, since again, that's my easiest analogy, is that if I just jump right in and do an ART session, it sometimes can work if I've just met the client and they are really motivated and someone's told them this is, this person knows what they're doing. But if I have the opportunity to get to know them a little bit and do an intake and understand their schemas better, then we tend to have a little better response. So I know what a lot of the ART providers in Hawaii are doing is that they'll do kind of an intake session to get to know them, and then maybe even do a second session where they just test out the eye movements, get people used to it, start to explore those schemas, start to kind of orient them to the idea of, working on their physical sensations and emotions before they launch into like a full session. There are different ways of approaching it. I do think it's really important to not forget about the importance of developing a rapport. Let's see, the effect of propranolol has in suppressing MRT. Um, Kim, can you explain what you mean exactly by MRT? Memory reconsolidation therapy. I'm sorry, got it. It is a cardiac medication. Propranolol is a beta blocker, so it basically prevents the heart rate from going past a certain point. So, whereas you might develop a racing heart in response to, you might experience your heart racing in response to something scary, propranolol will kind of cap that so you don't have that response. Now, whether or not that action is related to the memory reconsolidation, um, uh, what's the word, like prevention, if you will, we're not quite sure. I think scientists are still trying to figure out exactly why propranolol has this effect. May or may not be directly related to its beta blocking or cardiac effect. Prediction error may be the key intervention rather than the alternative memory. The alternative memory was a prediction error. Okay, James, yes. So the alternative memory can be the prediction error, but it's not the only way to introduce a prediction error. So yes, if you are able to create an alternative memory and the client is able to go with that and kind of, use that as something that they're willing to explore, I think that's a wonderful idea, and I would recommend it. Occasionally, you'll have patients that are a bit resistant to thinking about alternative memories, especially when there's moral injury involved or grief. They might think that they're dishonoring that person that was lost or those individuals by coming up with an alternative reality, or they may feel like they need to continue to punish themselves because of something they feel wrong. So, in that case, you may not be able to fully use an alternative memory, although I know in ART sometimes we just say, hey, we know no one can change what really happened, right? It just happened. But if you could make a movie about this or rewrite the script or come up with maybe even just an alternate reality, Earth 2 as opposed to Earth 1, what would that look like? And sometimes suggesting that alternate memory in that way can be enough for the person to overcome some of their resistance. Michelle, best way to deal with resistance to the process, clients saying they feel silly. Yeah, I think again, getting to understand this process that which is now has a good 20 years of research behind it as far as understanding both from, initial studies with rats and primates to now humans, really looking at the fact that once a memory is activated, you can change the not the explicit part of that memory, but the implicit or somatic part of that memory. That's okay to make those changes because they're never going to lose the original. Sometimes that can be helpful. I think you work in a military environment, and I know I always joke that like the people that were in the military the longest seemed the most resistant to thinking about things as silly. They kind of lose their creativity over time. But if you can kind of get people to think in a childlike way or remember what they might have been like when they were a kid, playing outside or going to Disneyland or whatever it was, sometimes that can be helpful in getting them to understand this like alternate reality. Yeah, yeah, military. Yeah. I'll stop there. I guess we're almost out of time, but if there's any additional questions, I'm happy to answer them.
I love how you say you saw it work so well, and so, you jumped on that. I mean, you didn't say it that way, but that is so cool that, you saw something so effective. You're like, yeah, I'm going to do this. This is great. Um, so, yeah, awesome. Thank you so much.
Sure, my pleasure. Thank you everyone for attending.
Yeah. For everybody online, we have Complex Trauma 101 next week, which I believe is part one of a three-part series by Amy Chung, faculty at UH. So that's exciting. Yeah, but this was really great. I mean, it's so wonderful to hear of new treatments that aren't just technology based or drug based. This is cognitive. This is going into the problem and working with it. Um, so you have somebody come in and you say, okay, tell me about a memory,
Well,
and then
usually,
it's that.
um, I mean, you could, but I think usually what it is that like they come in and they say, I was sexually assaulted and I know that I'm still working on that. Or sometimes they want to work on more vague things like I have this tendency to become codependent in my relationships. I mean, I've had that come up before. And as long as you kind of work it into a situation where you can get at those cognitive schemas and figure out what's driving the way that they're feeling and experiencing that trauma or that situation, then that's kind of where you would tackle it. So I think a good thorough history will often bring up several targets, and most of the ART therapists I know will kind of keep a list in their charting of potential ART targets so that they know that they can bring those up to the client almost as like a menu of what they want to work on. And the nice thing with ART, and I think one of the reasons it only requires 3 to 4 sessions, is that a lot of times the results will generalize. So you'll tackle one thing, and the individual will start to feel so much more calm about that and more confident in general that the other issues they were working on tend to lose their strength, and that over time they don't even need to work on every single thing. So that does happen quite a bit.
That's brilliant. Well, thank you so much. And you can see from the chat all the appreciation for you and all you do. Yeah, so everybody have a great day.
Thank
And
you.
see you next week.